Well, hello there, and welcome to this week's Be Informed webinar series sponsored by Bingham Healthcare. I'm your host, Michael Brandis, and we are live on Facebook right now. And so, just to let you know that if there are any technical difficulties, we are live, but we will continue to resume. And since this is on Facebook, please be sure to ask any questions that you might have. One of the reasons for this seminar is that we at Bingham Healthcare take great pride in hosting medical educational seminars for the community. And because of everything going on with COVID this year, we decided to do these remotely, and we've had a really positive response. So I'd like to, in advance, thank everyone for watching, who are watching these webinar series, and hopefully taking a great amount of information away from them. Just to let you know, I am in a studio with our doctor, who I will be introducing in a second. I wanted to let you know that we are in a socially distanced studio. We are 6 feet apart, which is why we're not wearing our masks at this moment. But as soon as we go off camera and we start interacting with one another, we put our masks back on. And I would like to say, on behalf of everyone in the community and through Bingham Healthcare, just think at this time, it's extremely important that everyone do their best to be able to stay socially distanced from one another, staying 6 feet apart. If you please try to wear a mask if you can. Again, you're hearing the same message. It's not only to help you, but it's actually to help prevent the spread of COVID to other people by wearing a mask. So we really appreciate the community's support in trying to do this, and we wanted to make sure that we mentioned that at the beginning of this webinar. So the way that this is going to work is I'm going to introduce our provider, give a little bit of background information on him, and then the second half of the webinar is actually a bunch of viewers have already emailed questions in and posted questions on Facebook, and so I'm going to be asking our provider those questions, and he will be answering those for all of our viewers. So again, if you're watching this, please feel free to share it. Please feel free to include any questions in the comment section. And if we will do our best to try to get to all the questions today, but if we don't, we will be sure to forward those questions on to our provider, who will then respond and get back to you. So first of all, I'd like to introduce Dr. Nathan Sneddon. He's a pain management specialist at Bingham Memorial Hospital. Welcome, Dr. Sneddon.
Thank you. Thanks for having me here.
You're welcome. So Dr. Sneddon works within Bingham Memorial Hospital and Bingham Healthcare. There's also a branch called the Idaho Pain Group, so that you'll hear those names synonymously with our pain group throughout Eastern Idaho. So again, Dr. Sneddon's specialties are interventional spine and pain management and anesthesiology, and he's trained as an anesthesiologist and fellowship trained in interventional pain management. So Dr. Sneddon, would you like to share a little bit about who you are, where you grew up, or where you were born and raised, and maybe about where you went to school?
Okay. I'll start with where I'm from. I'm originally from Lincoln, Nebraska, which is the capital city of Nebraska, for those who've never been there. Lincoln's a reasonably sized city, about 200,000 when I was growing up there. So my undergraduate degree was basically an exercise science degree. At the time, I thought I wanted to go into physical therapy. I mentioned this because, as you'll notice over the next few minutes as I answer your question, that my route to being a undergraduate major in exercise science to where I'm at currently as a interventional pain specialist is quite convoluted, and maybe there are those in the audience who have taken numerous trips and turns in their current profession that may be similar to mine. Looking back on it, I think everything happened for a reason. At the time, you have no idea why you're taking these twists and turns within your professional career path. I find the whole thing fascinating. So at any rate, I finished my undergraduate education at BYU University in Provo, Utah, and did my medical school back in Omaha, Nebraska at the UNMC Medical College there. So when I graduated, well, actually going going into medical school, my goal was to become what's called a physiatrist, someone who specializes in physical rehab medicine. I didn't do that, probably because I didn't have any experience in that field. There was no residency program in Omaha to give me any kind of experience. So as I moved through medical school, I knew I wanted to do two things. I knew that I liked to do procedures, and I knew that I really liked musculoskeletal pathology, injuries, that kind of a thing. And as a result, I naturally gravitated towards, of all things, orthopedic surgery. I applied to and matched into orthopedic surgery after completing a surgical intern year in San Antonio, and was doing orthopedic surgery for about 3 years. Now, orthopedic surgery is a 5-year residency, but by about year 2, I started to have questions on whether or not this was the right career path for me. I wasn't as happy as I thought that I would be. I wasn't enjoying doing surgery like most surgeons do, as much as I thought that I would be. And by year 3, it was becoming really clear that maybe I chose incorrectly. I looked at my options, and it's not uncommon, but still relatively rare for physicians to change from one career path to another. And I looked at switching to either physical medicine rehabilitation, which is what I thought I wanted to do when I graduated from undergrad, or anesthesiology. Without going into detail, anesthesiology, that switch seemed to be easier for me and maybe a better fit. Again, I had no real experience with what we call PM&R. And so I switched into anesthesiology, again, because I was not happy with orthopedics. I thought it was a good switch. I was planning on being a general anesthesiologist and putting people to sleep during surgeries, and I thought that that's what I would like. And then I had my first experience in my first required rotation in pain management. I had actually, truthfully, never heard of pain management, didn't know what it was, didn't realize it was a subspecialty of anesthesiology. I've since learned that 90% of the pain management programs, residencies in the United States, are anesthesia programs. The whole field of pain management evolved from anesthesiologists performing labor epidurals for laboring women decades ago. And that's kind of where the whole interventional spine and pain originated from. So I'm in my first month of this rotation. I'm actually within the first week or two, and I came out of a room where we had developed a plan to help this patient, and I don't know, I kind of caught on fire. I felt this is exactly what I was supposed to do all along in my career. Called my wife on my cell phone and said, this is what I want to do. She asked me, what does it mean for us as a family? I said, basically it means one more year of training, and she was okay with that. So at that point, we decided that after I graduate from anesthesiology, which I did a couple years later, that I would apply to a fellowship in pain management. I was accepted to a program at OHSU in Portland, Oregon, a very fine and fantastic program, I felt. Like most fellowship programs, it was a 1 year where I spent just, every day, all day long, practicing, seeing patients, and practicing what we call interventional spine and pain. Interventional spine and pain basically means that I take care of patients who have chronic pain, and in some cases we'll use medications, and that doesn't always mean opioids, but sometimes it does. But we also use maybe selective nerve blocks or epidural steroid injections or nerve ablations, or even things like what we call spinal cord stimulation to treat patients' chronic pain and kind of help manage their pain, allow them to function, allow them to live life the way that they want to. I graduated in 2015, so I've been in practice now for 5 years. And I look backwards at my background, my undergraduate major of basically a pre-physical therapy major, my years of orthopedic surgery, my years of anesthesiology, and they all have culminated together for me, have allowed me to really comprehensively look at a patient, comprehensively treat them, and do the best for them. And there's numerous stories I can share that kind of illustrate that fact. And I love what I do. I don't know if I would have thought that I would have said that a couple years ago, but I truly enjoy what I do. It's a difficult field. Patients in chronic pain, if you know someone or you are someone who has chronic pain, it affects all aspects of their life. It affects their marriages, their family, their work, affects their mood. It's not uncommon that they may suffer from depression or anxiety or irritability. All those are very normal problems that are associated with patients who suffer from chronic pain. And it's my goal to help in all those aspects of their care and get them better.
Thank you very much, Dr. Sneddon. That was fantastic. I really appreciate you providing us with that information. The two things that I heard, one of the things that I heard is you talk about chronic pain. It's my understanding that there's a difference between what people refer to as chronic pain and acute pain. Maybe just at a high level, if you could just describe someone who may not know that they're suffering from that. What are some of the symptoms, or what are some of the what are some of the symptoms that your patients present when they come to see you?
So that's a great question. Generally speaking, the difference between the two is largely just a matter of duration. Generally speaking, someone who suffers from pain that's onset of less than 3 months, generally we call acute pain. Patients who have suffered from a pain location or pain source ongoing for more than 3 months, we generally we call chronic pain. So for example, if Michael, you fractured your ankle, if you rolled your ankle outside here on the ice tonight, I would call that acute pain. I would call that acute fracture pain. I would not treat that the same way as chronic pain. You would, depending on your fracture, you may need a cast, you may need a walking boot, you may need surgery. But if that pain persists after the fracture is healed, after it's, quote, been fixed, but you have continued pain 3 years, 5 years down the line, I would call that more chronic pain. And there's certain diagnoses that we make in chronic pain that would allow me to appropriately treat you if that were to be the case, if that makes sense. Does that answer your question?
Yeah, thank you very much. And I was going to kind of, I was going to ask, can people direct refer? Can they call and schedule an appointment with you, or do they need a referral from their primary care provider or another provider to be able to see you?
So another good question. I think that's mainly a case-by-case basis. Okay. I'm okay with seeing patients without a referral. In fact, I saw a patient today who, this was the second visit I've seen her, and her first visit, somehow she got my name out of the newspaper, if I recall correctly. So she did not have a referral the first time that I saw her. I think some of that may depend upon your insurance and kind of your insurance plan. Some may require a referral from another physician, but generally not always.
Okay, thank you very much, Dr. Sneddon. I know that's a question that people ask quite a bit. Sure. The other thing that I wanted to mention to all of our viewers, and again, thank you very much for joining us this afternoon for our Facebook Live Be Informed webinar. I wanted to let you know that we are here with Dr. Nathan Sneddon. He's a pain management specialist with Bingham Healthcare, and he actually sees patients in both Idaho Falls and in Blackfoot. He sees patients in Idaho Falls at what is called the Comprehensive Cares Clinic, off of Sunnyside, just before Sunnyside and Hit Road. It also has Bingham Healthcare on the building. It's a multi-specialist building. We have almost, I think, 20 providers that have all different specialties that work in that building. It's really it's really about Bingham Healthcare moving and closely lining with the Mayo Clinic, model, where you can find all of these specialists under one roof, and you don't have to drive all around town to be able to get treated. So, like, for example, if you're seeing an orthopedic surgeon, then you could see Dr. Sneddon for pain management in the CCC. We have family medicine specialists in the Comprehensive Cares Clinic, and a number of different specialties. And you can find that on our website at www.binghammemorial.org. Again, www.binghammemorial.org for all the information about all the specialists at the Comprehensive Cares Clinic. So he sees patients in Idaho Falls, and then he also sees patients across the street from Bingham Memorial Hospital at 98 Poplar Way in Blackfoot. So it's convenient for patients that need to travel or that can't travel from Idaho Falls or from Pocatello. It's easy for people to get from Pocatello to Blackfoot to see Dr. Sneddon. And the other thing I should remind you is that we at Bingham Healthcare have a transportation service. So if you, for some reason, you are unable to drive, or if you're unable to drive, when you call and schedule an appointment with any of our providers, including Dr. Sneddon, you're more than welcome to ask the front office staff who's scheduling their appointment to say, hey, can you help organize the transportation? And it's a service that it's free, and it's a service that we take that we're very proud of, and we're glad that we can offer to the community. Okay, so why don't we go ahead and move into some of the questions that are coming through right now in the Facebook comments for Dr. Sneddon. So before we move into the questions, I do wanted to provide our viewers with a disclaimer, just to let you know that even though Dr. Sneddon is a trained doctor and he's providing answers to questions that our viewers have provided, just have to let you know that it's not considered a medical diagnosis. It's just his general opinion, his general thought on what's going on. But in order for it to be confirmed, you actually need to either meet with your provider, or you need to meet with Dr. Sneddon in person, or through telehealth visit, online or over the phone, if that's applicable. You'll need to meet with Dr. Sneddon, and he can evaluate you and talk to you. So then that's when it officially can become a diagnosis. So I just wanted to make sure I preface that for all of our viewers today. Okay, so Dr. Sneddon has already talked at a high level about what chronic pain is, long-term. I would say, you could say long-term pain, and acute pain I would consider to be short-term pain. So one of the first questions, Dr. Sneddon, that we have is about opioids. What are some of the side effects to chronic opioid use, and are these medications fine to take in moderation?
So important question in 2020. For those who don't know, I assume most know nowadays, most health experts have considered us to be in a opioid epidemic of some sort, which is probably what prompted this person's question. Opioids have historically been used to treat pain, and up until 1990, for the most part, had been used just to treat acute pain, post-surgical pain and such, and was relatively rarely used to treat chronic pain. In fact, you could easily say back in the 60s, to prescribe opioids long-term, you probably lose your license, your medical license. That's changed, obviously, nowadays. So it's important that people understand, maybe you have a loved one who's on opioids, maybe you're on opioids. There are risks with any medication that you're prescribed, and your physician, your prescribing physician, should always have those types of conversations with you. So I bring that up because the most common side effect people think about these days is addiction, or opioid abuse, or misuse, or overuse. Those types of behaviors. Now, I like to reinforce my patients, not everyone can become addicted to opioid medications. Not everyone does become addicted. Certainly people do. There's no question about that. But there's a difference between opioid addiction and opioid dependence. And this is a really key point that I like to make, especially with loved ones in the room, because oftentimes I hear loved ones, label or accuse the patient of, quote, being addicted, when in fact the patient's not addicted, they're dependent. I explain to patients that basically addiction means a patient is overusing medications, knowingly doing so. The use of the medication has kind of overtaken their life to the point that they may be lying, they may be stealing, they may be spending money. Their focus is all about getting and or using opioids. That's different than opioid dependence. Dependence implies that if you suddenly take away the medication, patients will have withdrawal symptoms. I like to use the example of blood pressure medications. If someone's on a blood pressure medication, they're going to be dependent on that medication. If you take that medication away, or you suddenly decrease its dose, their blood pressure is going to go up. Likewise, with opioid, they may have withdrawal symptoms. So again, most common side effects that we think about these days is addiction, dependence, etc. But those are not the only complications or side effects with opioids. There's actually several other complications. There's There's mood alteration. Patients can get depressed with chronic opioid use. There is effects on bone health. Patients can develop osteoporosis and therefore be more prone to fracture with chronic opioid use. There's, of course, allergic reactions. There's constipation. There's itching. There are hormonal changes, and these are important. I like to impress to both men and women. Men can develop low testosterone just as a result of being on chronic opioids. Women likewise can have hormonal changes, both of which can lead to decreased libido and, again, poor bone health. And of course, the one side effect that we really worry about is a high dose of opioids can cause respiratory depression, which can lead to basically overdose and death. And that's been the big worry in our country for the last, I'd say, 4 to 5 years. So I think the other question you'd asked was, are these medications okay to take in moderation? Was that correct, Michael?
Yeah,
okay.
Absolutely.
So that's a great question. Generally speaking, I would agree that is okay based on what we know now. But that term moderation, I do think varies from person to person. The CDC came out with basically some recommendations relative to prescribing opioids. Those recommendations were published in 2016, and it really changed the whole landscape of chronic opioid therapy that we in pain management prescribe. Not just us, but also primary physicians. And what it resulted in was patients suddenly being decreased on their medications in terms of either frequency or dosage or use altogether. And it unfortunately has resulted in a lot of confusion, both at the level of patients, families, pharmacies, insurers, and arguably the U.S. government. Thankfully, we're now, 4 years back from that. We've taken a step back and realized that maybe we installed some of these changes too quickly, if that makes sense.
Okay.
But generally speaking, we know there are levels that are, quote, too high, generally speaking. And I make that distinction because when chronic opioid therapy became more of a thing back in the 1990s, we were sold more or less on poor data that patients could be on as high doses as was necessary for the pain to be controlled, and that there was low risk or no risk for addiction and low risk or no risk of overdose and death. And obviously we know those things were not true. Those were lies. And so we've taken a step back as a medical profession and as a society and basically said, hey, this is not safe in these high doses. We need to curtail it back. And I think in moderation, there is some benefit. I see patients on a daily basis. I saw one today, a woman nearly 80 years old who's got a bad knee, and she just takes a small dose of an opioid medication. I think she takes it once or twice a day, and she does fine. And I have really no worries about opioid abuse or addiction in her case. But again, every patient is different. You got to really tailor your care to the patient in front of you. You can't treat them all like a number.
Okay, thank you, Dr. Sneddon, and thank you to our viewer for asking such an important question. I know that's been on a lot of people's minds in the last couple of years. The other thing I think I wanted to talk to you about, Dr. Sneddon, is I think that sometimes people have the misperception that every time if they go to see a pain management specialist, I would imagine that people have a fear that you're just going to automatically put them on an opioid or a pain or some kind of pain, give them some kind of pain pill. And I just wanted to have you elaborate on that, just to say that maybe that is or is not the case, and to talk about the whole host of other ways that you can treat people without having to, prescribe pain medicine.
Yeah, so that is a very, very good and important point that I always try to make when I see patients, which is that is totally a true misconception in our society. I've talked to patients or even friends of loved ones who have said, that they think that's all that we do is prescribe opioids. Or I've had patients say, when my primary physician referred me to you, I burst out in tears because, quote, I thought that you were just going to feed me with pain medication. And so that is a tool in our bag that we use when and if appropriate. But in my personal case, it's rarely the tool that I go to. You ask any of my patients, if they come to me and they're not on a narcotic, they rarely leave my office with an opioid, rarely. And if they do so, it's not after I've been seeing them for months and months and we've tried other things besides medications. Again, it all depends on what is the diagnosis, what's the source of the patient's pain. Is it back? Is it neck? What part of the back is it? Is it hip joint? Is it knee joint? Is it something more elusive, say a diagnosis like fibromyalgia, which many people have heard of, or is it something that's related to their diabetes? These are all common pain sources that I treat, and in some cases, patients are great candidates for using interventional or injection methods. In other cases, medication really is the way to go. And honestly, you have to treat the patient as a whole. You have to look at their family life, their job, their mental status. Do they suffer from depression and anxiety? Is that being adequately addressed? Could they benefit from a medication in that realm? Heck, could they benefit from therapy or even counseling? These are all things that I look at because I like to treat the whole patient, not just the body part.
That's excellent. Thank you very much for elaborating on that, Dr. Sneddon. So moving into back pain, one of the questions that our viewers is asking is, what's the best? I know this is very high level, very general, but maybe you could kind of go into a little bit more depth with this, because I know that it just depends on the patient. What's the best thing you recommend for back pain?
Okay. Yeah, so that's that's really open-ended, big question. But I think there's some generalities that you could, or I guess I should say some specific recommendations you can make to every person, regardless of who they are, that would somewhat answer that question. But of course, it would have to be individualized. Generally speaking, the best thing that I recommend for back pain is if there's weight to lose, you lose it. And generally speaking, when you're talking about weight loss, and I'm not an expert in weight loss, and I don't pretend to be an expert in weight loss, but generally speaking, diet changes are more important than exercise. I don't know, you can't see me here on camera. Growing up, I was always kind of small and quote unquote skinny. I was a runner my entire life. That's what I still enjoy doing. I do a lot of ultra marathons and trail running these days. But as I've aged, I've gained weight that I want to lose. And I've learned the hard way that no matter how many miles I run, no matter how many marathons I run, I still have this gut. I blame my dad, by the way, that I've learned over the last few years, the last couple of months, that me making changes in my diet has done a better job for weight loss than running more miles or running more hours. Okay. So number one, I think, is weight. If you're overweight, I encourage you to do whatever you can or need to do to get back within a normal weight limit. The second thing I highly recommend is get in with a good physical therapist. You notice that both of these recommendations have nothing to do with me. I don't gain any money by these two recommendations, but I absolutely believe in them. Get in with a good physical therapist. Get someone who will know how to properly stretch and strengthen your core muscles. And I explain to patients, core muscle strengthening does not mean the abs. Well, that's what we think about because that's what we've been fed by magazines and Hollywood, etc. Core muscles are basically anything from basically your chest to, I would say, mid-thigh. So we're talking about your quadriceps. Yes, your stomach muscles, meaning your six-pack, but your obliques, your gluteal muscles, your pelvic flexors, all these muscles, your hip stabilizers, all of these need to be strengthened and stretched. The fact is, we as a society are generally more sedentary. Most of us work at a desk. Most of us do some kind of an office job. Even myself, I spend most of my time sitting and talking to my patients rather than lifting or doing this or that. So in those cases, we need to work on strengthening our core. And I think getting in with a physical therapist would be helpful for that, or, into the gym. But even the gym is not adequate because you don't really know what you're doing unless you have some kind of a background in exercise science or what have you. So those are the two main items I would recommend for a generalized question like that about what do you recommend for back pain. Other than that, it really depends on the individual. It depends on their symptoms, depends on the duration of their symptoms. It depends on whether or not there's any kind of neurological complaints, those kind of things.
And I would say to this viewer, and perhaps you can add on to this as well, Dr. Sneddon, is when we were talking a little bit earlier about chronic pain or long-term pain and short-term pain, I would say for the back, if it's something maybe you just tweaked it, you got out of bed wrong, or you were walking on ice and it kind of jarred yourself a little bit, there are things you can do for that, and if it's short-term. And then that'll, eventually the muscle heals, or, and everything like that. But then if you're experiencing ongoing back pain that's persistent every day, then that's when I would recommend calling Dr. Sneddon's office and talking to the front office staff to see if you could schedule an appointment with him based on some of the symptoms that you talk about. Would that be good advice, Dr. Sneddon?
Yes and no.
Okay,
and I apologize if I disagree with you to a certain degree. Let me be a little more specific. So generally speaking, we know that in medicine, patients who have new onset, or what you would call acute onset, low back pain, without symptoms that go down into the legs, without neurological complaints like numbness, tingling, or weakness, generally pain just in the back. In those cases, if the onset is acute, research has shown that it doesn't matter, generally speaking, it doesn't matter if the patient goes to a chiropractor, a physical therapist, gets placed on anti-inflammatories or muscle relaxers or opioids, or gets an MRI or gets injections. In most cases, patients get better with time. So we recommend against bed rest, which is what we used to recommend. We used to recommend just bed rest.
Okay.
So now we recommend against that, kind of push through it, maybe slightly modify your activities, but not go straight to just, I'm going to lay around and just wait for myself to get better. What that does instead is decondition the muscles in the back and again in the core, and it's going to make you weaker and more susceptible to injury. Now, the exception to what I just explained to you is if you're having leg symptoms, pain, numbness, tingling, weakness, in those cases, you may want to see a physician sooner rather than later. You may require an MRI. Again, it depends on the symptomology. It depends on the physical exam of whatever practitioner you're seeing. And yeah, in that case, you may benefit from getting an MRI, and you may benefit from doing an injection. But again, back pain that doesn't go down the legs, stays in the back, acute onset, you don't want to just be sedentary. You don't treat with bed rest. And if anything, I would recommend therapy to start with.
Okay, that's awesome. Thank you very much, Dr. Sneddon, for elaborating on that.
Sure.
And it ties into our next question, actually. Maybe this is a little bit more specific. So for lower back pain, I suffer from chronic back pain, which Dr. Sneddon has just been talking about, and I don't want surgery. What treatment options are there for me, and how long after treatment would I expect to have relief? So I know that's a little bit general, but maybe if you could talk a little bit about that.
Okay. So this is a little bit of a difficult question, primarily because it is generalized. I'll tell you how I would approach a patient in such. If this patient were in my office, so if the patient has chronic back pain, so their pain's been present for at least 3 months. In most of these cases, it's been there for months, if not years. Some of my patients say they've had back pain for decades. They say they want to avoid surgery. My purpose, my goal as an interventional spine specialist is always to establish a diagnosis. I feel like I'm not a spine surgeon, but I understand the anatomy of the spine basically as well as a spine surgeon does. And so I look at the spine and ask myself, what's the diagnosis of this patient's chronic back pain? Is it the discs? Is it the bones? Is it the small joints in the back of the spine called the facet joints? All those could be possible causes of back pain. It could be the sacroiliac joint, which is actually below the lumbar spine. It could be muscular. Maybe the patient is deconditioned and they actually suffer from core weakness like we discussed earlier. And believe it or not, and some patients don't want to hear this, but the fact is some patients just have depression, and that's manifested physically in the form of back pain. That's not uncommon. And that doesn't mean the patients are crazy at all. Pain is real, but all pain is sensed and perceived at the level of the brain. So I, talked with Michael earlier. We used the example of if he had fractured his ankle, for example. That ankle fracture is real, but he's going to perceive it in his brain. And so there are cases where we go to the level of the brain to treat pain. It's not frequent, but we do it where it's appropriate. But like I said, it's rare. So again, it all comes down to establishing a diagnosis. There are several different ways to treat back pain if it's originating from the spine, all of which I feel I specialize in and get good results.
Okay, thank you, Dr. Sneddon. And to the viewer that submitted that question about lower back pain, we thank you very much for taking an interest in our webinar today. And again, if this is something that is, obviously this has been going on for a long time, feel free to schedule an appointment with Dr. Sneddon, and he can really help to work with you and come up with a diagnosis and understand the root of what's going on, and then be able to come up with a solution on how to help treat you. So hopefully that we can have that taken care of for you. Excuse me. The other thing I was thinking about, Dr. Sneddon, when we talk about back pain, is that this is probably a little bit general too, but maybe you could just, at a higher level, talk about what are some of the more, and I know exercise and strengthening your core is the prevention to this. I'm putting the cart before the horse. But what are some of the more common back injuries that you see, or are there just a wide? But I would imagine there's just a wide array of back injuries that people, how they injure themselves. If they lift something wrong, sitting at a desk all day, what are some of the things that you see that you could maybe provide our viewers with a little bit of an awareness? What precautions that they could be taking?
Well, so to simply answer your question, it comes back to what I discussed, which is strengthening that back and make sure they don't have weakness. Now, that being said, I have plenty of patients who are athletic patients who have, as far as I can tell, are strong, and they still injure their backs. I had a neighbor of mine before I moved to Idaho who he's a hunting guide. He does guiding trips into Montana and here in Idaho, and I treated him for a disc herniation. In his case, really healthy guy, young guy, athletic guy, had a 40-pound back on his back, had slipped and kind of caught himself. And he said, I knew then something was wrong. And he felt a new pain in his back that slowly went down his leg. And we discovered that he had disc herniation, treated him with an epidural steroid injection, and his leg pain and most of his back pain went almost away completely. And the goal in that was to help him to avoid surgery. So you can injure your disc. You can herniate a disc, which is different than a disc bulge. I make this distinction because people come to me, they have a MRI in their hand. We reviewed the MRI, and it will talk about disc bulge at this level and this level and this level. And I try to explain to patients that disc bulges are rarely symptomatic, and I usually, for the most part, ignore them. That was based on a study published a few decades back where they had done lumbar MRI on hundreds of patients, all of which had no symptoms. And they showed a high prevalence of disc bulges, proving that disc bulges don't really correlate to pain, if that makes sense. But disc herniation is real, and that's an injury. that can happen. You can fracture the back, but you can fracture the back multiple ways. In the young, generally speaking, you're seeing like a burst fracture, someone has a fall, or some kind of weird twisting injury, some kind of high velocity injury is more common in the young. But what I actually treat is what we call a fragility or compression fracture. That is more likely to happen in someone who is elderly, who has a diagnosis of osteoporosis. And in their cases, there may not be a significant inciting event. I treated a patient several years ago who her inciting event was she was getting ready for her bridge game. She had a weekly bridge game, and she was grabbing a stack of chairs and dragging them across the room, and she felt a sudden pain in the middle of her back between her shoulder blades. We diagnosed her with a new compression fracture, and that's a source of pain that again we can treat without using pain medications. Historically, that's what they would do. We would put a patient in a brace for a fracture and treat them with pain medication and put them on, quote, bed rest. And we've learned that actually does more harm than good. There was a study published in 2015 out of, not the Mayo Clinic.
Cleveland?
No, not Cleveland Clinic. I'm sorry. Baltimore.
Okay.
I'm embarrassed right now. Anyway, the major medical center there. This study showed that patients who were treated for compression fracture using an intervention that I do called kyphoplasty actually reduced their mortality rate compared to patients who were treated with the traditional bed rest, opioids, bracing. So I know we've kind of got off on a tangent there. Back to your question, which was what injuries can take place. Like I said, fractures, disc herniations, and the like.
Are you referring to the Baltimore VA Medical Center by any chance?
No, Johns Hopkins.
Johns Hopkins.
Johns Hopkins. I'm embarrassed. I apologize for any of my friends who went to Johns Hopkins, including one of the fellows I trained with at OHSU. That's where he does his residency, was Johns Hopkins. So I apologize.
It's the one that I never really associate with being in Baltimore. I have to write about all these different medical centers and research on them, and I never associate with them with being in Baltimore for some reason.
Sure.
The other, when you were responding to that, you talked about a herniated disc. And I don't know, is that synonymous with a slip disc? Or maybe if you could define what that actually is.
Okay.
Is that a good question?
Yeah, that's a totally good question, because people come in and say, my vertebrae has slipped or my disc has slipped. That's a misnomer.
Okay.
It doesn't exist. A disc herniation is the proper terminology. What it means is, I explain to patients that the discs between the vertebrae in the spine, those discs I liken to a jelly donut. You have the inside of the disc, which is mostly water, and where most of the cushion is. We call that the nucleus pulposus. On the outside of the disc is like the dough of the donut, so to speak. That kind of keeps that cushion where it belongs. A disc herniation is where that middle part of the disc herniates or vaginates outside of that outer level. And it's that inside nucleus that has been shown in vitro studies to be really pro-inflammatory towards spinal nerve roots. So whether that substance leaks out and causes more of a chemical inflammation, or leaks out and actually causes a mechanical pressure pushing the nerve, both those can cause similar symptoms, which is primarily pain in the back that radiates down into the buttock or the thigh or the leg in a defined or predictable pattern, if that makes sense.
Okay, thank you for elaborating on that. So the next question that we have is related to general pain. I feel like you've already touched on this topic, but I at least wanted to mention it for the viewer that submitted it. And so the question from our viewer is, can my pain be cured, or is it only going to be managed?
Okay. So obviously difficult question to ask, answer, given the generality of the question itself. When someone comes in complaining of general pain, so in my practice, we have the patients fill out a fairly comprehensive intake form. It's 2 to 3 pages long. And on it is a diagram of a person's body where I ask the patients to circle, where your painful areas is. Is it the knee? Is it the back? Is it the shoulder? Is it the neck? Etc. Not uncommonly, I'll walk in and that figure will basically be circled everywhere. I mean, everything is circled. I call that generalized pain. I don't know if that's what the viewer is referring to, but that's what it sounds like they're referring to, is this generalized all over body pain. In most of those cases, not all, but most of those cases, those patients likely suffer from something that we have termed fibromyalgia or something similar to it. Now, I want to make this distinction because you'll hear lots of conflicting views or opinions on fibromyalgia. You will meet medical practitioners, and I've met them, and I've heard medical practitioners of, whether they're doctors or nurses or what have you. I've heard some think that fibromyalgia doesn't exist, that it's a quote, a made-up diagnosis. Now, the diagnosis of fibromyalgia was created by the American College of Rheumatology well over 10 years ago. I personally believe it's an absolutely real diagnosis, and I treat it, and I've had really good success in treating it. Basically, what we know, and I worked with a researcher at OHSU in Portland who did research relative to fibromyalgia. Now, she was looking at this is interesting, Michael, for those who may suffer from fibromyalgia or similar related syndromes. They were looking at functional brain MRIs and looking at what areas of the brain light up or are active in these patients. And what's interesting is they noticed that patients who had a diagnosis of fibromyalgia likely also suffered from chronic migraine headaches and or suffered from irritable bowel syndrome. And for those of you who don't know what irritable bowel syndrome is, symptoms of chronic abdominal pain, maybe bloating, maybe constipation, maybe diarrhea, but biologically they've had a colonoscopy or they've had a scope down their mouth and everything checks out fine, quote, no diagnosable cause. What they learned in these functional MRIs is that commonly they would have fibro and or IBS and or chronic migraine. This researcher's theory, her hypothesis was that these are all manifestations of the same symptoms. So we use the term in pain management called centralized pain. The viewer used the term generalized pain. I would change that and call it a centralized pain. Well, what does that mean? We know there's pathways that communicate the sensation or the experience of pain from the peripheral of the body, whether it's a fractured ankle in my made-up case with Michael or something else. We know there's these pathways of pain where the pain is ultimately perceived in the brain, okay? In a case of centralized pain, well, let me back up. So those pathways, there are neurons in the spinal cord and in the brain that will amplify that signal of pain, and likewise there are pathways that depress that signal of pain. So like, we use the term natural endorphins. Those are one of those natural neurons that kind of depress that signal of pain. So going back to the viewer's question, patients who suffer from generalized pain, for example, fibromyalgia may be an example of that, their pain is more of a centralized location. What we're learning is those neurons that amplify the signal of pain, for whatever reason, in their case, is more amplified in their case compared to maybe me or Michael, who doesn't suffer from that pain. So what that means is stimulus that are normally not painful is painful to them. So someone who has fibromyalgia, they're tender all over, and if you just touch them slightly, it causes pain. Whereas you touch me slightly, it doesn't cause me pain. Things that are normally painful for me and Michael are really, really painful in their case. So again, those centralized neurons and I say centralized because it's in the central nervous system. So brain and spinal cord, those pain pathways are amplified rather than de-amplified.
Okay, excellent. Thank you for elaborating on that, and hopefully that was helpful to the viewer that asked that question, and anyone out there suffering from fibromyalgia. You did mention in there migraines, and I think I'd be remiss if I didn't ask. So if anyone out there is suffering from migraines, Dr. Sneddon, do you treat migraines?
I do. I do, and I feel very comfortable in treating them. I know I'm not a neurologist, and there is a little bit of overlap between what I do and what a neurologist does. But I feel very confident in, number one, making the proper diagnosis. You know, are these migrainous headaches, or are they something else? And sometimes, not all the time, but sometimes patients have been misdiagnosed for several years. So my argument in whatever it is I do is always try to establish the proper diagnosis, and then that should determine the treatment plan. So in migraine, there's so many different types of migraines. Is it chronic migraine? Is it acute migraine? Is it chronic migraine that's well controlled? Or is it chronic migraine where they basically have daily headaches? So what I like to do is establish the diagnosis, number one, and then establish the severity of that diagnosis. So if patients have a migraine headache a couple times a month, maybe no more than 4 times a month, they should be on a medication that aborts or stops migraine headache. We call that migraine abortive type medications, commonly like Imitrex or Maxalt, if you've ever heard of those,
Okay.
are used for those types of medications. But let's say you're a patient who you actually have migraines, like 8 migraines a month, maybe 10 migraines a month. That patient probably needs to be on a migraine preventative medication. Commonly, they may be a blood pressure medication like propranolol. Maybe they're a medication like Topamax. Topamax works really well for most patients, and the advantage of Topamax is one of the side effects is causes weight loss.
Okay.
But not everyone responds to Topamax. In some patients, they've tried multiple medications for migraine prevention, and nothing has worked, and they have more than 15 days of headaches a month. And I use the term days because that's what insurance requires you to say.
Oh.
If they suffer from more than 15 headache days a month, they may be a candidate for Botox injections for migraine prevention. I did one of those today on a patient of mine. She sees me every 3 months, and we do Botox injections for her. And more recently, there's a whole new class of migraine preventative medications that were just approved by the FDA last year that works a completely novel mechanism of action. And that's just an injectable where the patient or maybe a loved one will actually just inject the patient once a month to prevent their migraines. And in some of the cases that I've been seeing, they work really, really well. So again, you just have to individualize the treatment.
Okay.
So, yeah.
Awesome. Thank you. Now, another question from our viewers is, this one's very specific. It's about spinal canal narrowing. Will a cortisone injection or any injection stop spinal canal narrowing? And if not, what are options to stop the process if any of the spinal canal narrowing? Maybe define what that is first, and then
so that's a really good question, and really common, especially in your elderly patients, your patients over the age of 60, especially over the age of 70. We use the term spinal stenosis. Stenosis means narrowing. The spine is basically canal. It's a canal that within it is the spinal cord, this fluid surrounding the spinal cord, and the nerve roots that come off of the spinal cord. Now, the spinal cord actually typically ends around L1 or T12 in most individuals. As you descend down in the spinal canal, instead of the spinal cord being there because it's stopped, you have these nerve roots. And so you can have narrowing of the spinal canal. Again, we call that spinal stenosis. But where the nerve roots come out of the spinal canal or out of the spinal column, that can also be narrowed. We call that stenosis as well. Without using too big of terms, one is foraminal stenosis, one is canal stenosis, okay? So the stenosis is usually caused by multiple factors. Yes, it can be caused by disc bulging and or herniations, but more commonly can also be caused by arthritis of those small joints in the back of the spine I referred to earlier as the facet joints. In most cases, it's a combination of the two. In some cases, patients, believe it or not, have so much, they're so overweight, we actually have too much fat in the epidural space that can cause spinal stenosis, in addition to the other factors that I just named. So that just kind of helps you understand what is spinal stenosis and what are the individual factors that can cause spinal stenosis. Now, the question I think was, will a cortisone injection help it? What can cause it to worsen? Generally speaking, there's not much that a patient can do to stop its progression that I know of. Now, not all spinal stenosis is symptomatic. I promise you there are hundreds, if not thousands of people out there who have stenosis that is either causing very or little symptoms. I have a patient of mine, he's got a horrible looking back, but I would have thought that he would have needed surgery years ago, and he doesn't. He controls his pain with some medications, and I do some injections on him, and he does well. His injections last him a few months, and he comes back for his periodic injections, and he does great. So that comes back to this question about cortisone injection stopping the stenosis. The cortisone injection is not going to stop the stenosis itself. Most stenosis is a bony problem. That's related again to arthritis, and the cortisone injection is not going to stop or necessarily even slow that process down. Forgive me if I'm getting into too much specifics. I think it's important, and it's kind of fun for me to talk about, that patients understand this. What the stenosis is doing is it's basically compressing or pinching those nerves. That in and of itself does not necessarily cause inflammation, but what it does is it causes decreased blood flow to the nerve. So we talk about heart attacks in the heart. That's where blood flow is decreased to the heart muscle, and patients get chest pain. In this case, you get decreased blood flow to the nerves, and what that causes is back pain and often leg pain. And generally speaking, those leg pain and back pain is worsened with patients who stand or walking, and improve when patients sit down. These are the people that you see at the Walmart or at the Brolims who are leaning over, bent over on the cart. They usually have a degree of spinal stenosis. And the steroid injections aren't necessarily going to change the progression of the stenosis or the narrowing. But like the patient I referred to you earlier, he's a patient of mine down in Blackfoot. Great guy, golfer. He's in his 60s. Love him to death. I won't tell you his name. Great guy. I do periodic epidural steroid injections for him that reduce his symptoms. They're never going to change his stenosis or improve his stenosis, but they reduce his symptoms of pain and most recently allow him to golf. And that's what he likes to do. So.
Okay, that's great, Dr. Sneddon, and thanks, to our viewer out there. Thank you very much for submitting your question and for participating in our Be Informed webinar series. So, Dr. Sneddon, just as we're live on Facebook, just wanted to let you know that we're running low on time. So I have one more question that I'm going to ask Dr. Sneddon, and then open it up to him to see if there's anything else that he would like to talk about that he didn't have the chance to talk about today. And if for those of you who are watching, if you have submitted questions that Dr. Sneddon or that we've been unable to answer, please know that we will be forwarding those to Dr. Sneddon, and we will be responding to those questions. So still, please feel free to submit your questions, and just know that we have a social media team that will work with him to be able to respond, so that everybody who's participated and submitted questions is taken into consideration. That's the main reason why we're hosting these, is we want to be able to provide you with the information that you need to make informed medical decisions. So, Dr. Sneddon, one of the last questions that we have here is which I think is a good one, because I think people take over-the-counter or OTC medications for granted and may not always know what they do or how they work, or maybe how they don't interact well with each other. So the viewer's question is there a certain over-the-counter pain relief that is better for you than others? And I know that's circumstantial. For example, is it okay to take Tylenol or ibuprofen for my pain?
Okay. Decent question. Really, those are the only really over-the-counter medications outside of naproxen, otherwise known as Aleve, that patients can take over-the-counter. Otherwise, most everything is by prescription only. But I like the question because I encounter it a lot in my practice, and I like to correct some misnomers or some misunderstandings. So, for example, patients will say things like, I don't want to use Tylenol because I'm worried about my kidneys. Or they'll say, I don't want to use ibuprofen because I'm worried about my liver. And I have to correct them a little bit. So long-term use of any anti-inflammatory, and an anti-inflammatory is ibuprofen, naproxen, otherwise known as Aleve, or any other medications within that class. I do not consider, and most people should not consider Tylenol as an anti-inflammatory. Okay, so long-term use of anti-inflammatory, if you talk to your friendly nephrologist, and I'll do a shout out to Dr. Hatterley, one of my friends, or Dr. Rahim, one of my other friends, they will tell you that long-term use of anti-inflammatories can reduce kidney function because it can reduce the flow of blood to the kidney. So that's something that patients have to be aware of.
Wait, I'm sorry to interrupt, but when you say long-term, what would be the parameters of long-term?
Generally speaking, I would say years. That's a great question.
Okay.
And it varies from patient to patient. I would say generally years, not a few weeks, generally not a few months. But when you're talking about years, that's where you say, you got to be wary.
Okay, thank you.
No, great question, great question. The other concern you have with long-term, again, months or years of use of any anti-inflammatory like ibuprofen, especially high dose, daily dose, and or Aleve, would be gastric ulcers or gastric upset or reflux and those kinds of things. So those are the two things you want to worry about with anti-inflammatories is stomach and kidney, not liver. Okay. Now, Tylenol is probably one of the safer medications out there, generally speaking. That's probably the reason why, along with ibuprofen, it's over the counter. Long-term use of Tylenol within the current guidelines, as far as I know, you're not going to have any problems. Now, overuse, and by overuse, I'm talking about overdose. You can have liver toxicity, you have liver failure, but you're not going to do that as long as you're not using higher than the recommended dosage. The former recommended dosage used to be 4,000 milligrams a day. That was changed recently, a couple of years ago. Now we're telling patients not to take more than 3,000 milligrams a day. So if you do the math, if your usual Tylenol is a 325 milligram tablet in most cases. You can find a 650 milligram tablet. The extra strength or the arthritic strength Tylenol is usually a 500 milligram. It's a 500 milligram. You don't want to be using more than 6 a day. And keep in mind, if you're someone who's being prescribed an opioid medications, for example, a hydrocodone or an oxycodone, often those will be a combination with Tylenol. So you have to be aware that if you want to supplement Tylenol on top of that, you got to be careful. You got to add up and make sure you're not using more than 3,000 milligrams a day. Okay. Second question, patients will often ask me, can I use Tylenol and ibuprofen simultaneously? You absolutely can. Now, you can take them at the same time. I usually like to kind of stagger them. If you're, again, it depends on the patient. It depends on what pain you're trying to treat. But generally speaking, you could use an ibuprofen and then follow it up in a couple hours with a Tylenol. And again, as long as you're matching the parameters that I've talked about. So for example, ibuprofen, maximum daily dose is 800 milligrams 3 times a day. So if you do the math, that's 2,400 milligrams a day maximum of ibuprofen. And you do that here and there for a few weeks or a few months, I'd be okay with it. But you should not be doing that month or for years for the reasons that we already talked about with gastric upset and especially kidneys. Okay.
And so with ibuprofen, is my understanding, I kind of maybe just to reiterate what you were saying, I think of ibuprofen as an anti-inflammatory,
yes,
and then maybe more of the Tylenol has the acetaminophen in it, which helps with pain.
Right.
Is that correct?
Right. And they both actually help with pain, but Tylenol, yes, is not technically seen as an anti-inflammatory. And FYI, Tylenol and acetaminophen are the same thing.
Yeah.
So Tylenol is the brand name, just like Kleenex is the brand name of tissues. Tylenol is the brand name of acetaminophen. So,
yeah, and the other thing that I just thought of is I thought it was interesting, and I was a little bit, I didn't know this, but I just saw that recently ibuprofen came out with one that has both acetaminophen and
There you go.
ibuprofen.
There you go.
I don't know where I saw that, but anyhow, well, I'd like to take this opportunity to thank you very much for being with us today, Dr. Sneddon. I feel like it's been very informative. Thank you very much.
Good.
At this time, now that we've had this really great conversation, are there any other topics that have kind of popped up in your mind that you've thought that you wanted to elaborate or talk about? Or do you feel like you've talked about, given a pretty good picture of your services and what you can offer to the community?
So I would like to elaborate on a few things, some common questions I get from patients and some common misnomers that patients may get. We talked earlier about, opioid medications or how to treat back pain, and I've touched on some of this. What I try to explain to patients is that there are multiple ways to treat back pain. Again, after you have properly diagnosed where the patient's source of pain is from. Sometimes patients do well with epidural steroid injections. We've talked about that. Sometimes patients just have back pain that does not radiate down the legs, and that pain's actually coming from the arthritic facet joints. I do ablations for that, and that has good evidence. We've been doing that for decades, and patients do really, really well with that. I did 4 patients ablations on Monday, so that's a very common procedure. But some patients say, I've done all that before, and I got back surgery, and I'm still in pain. I still have back pain, or I still have leg pain. What are my options? There are other options. There's a procedure that I do called spinal cord stimulation, where I actually place an implantable device that basically turns off the neurons within the spinal cord to basically stop that signal of pain going to the brain. So I basically stop the pain at that level, if that makes sense. That's a really generalized statement. I would much rather describe that or discuss that more in person with the patient. But that is an option for patients who've had previous back surgery and they may feel like there are no other options. Some patients will come to me and talk to me about back surgery. Maybe they're contemplating back surgery. And I like to tell them that not everyone needs back surgery, but at the same time, when appropriately done by the right surgeon with the appropriate diagnosis in mind, some patients actually do well with back surgery. More often than not, I'm seeing patients come into my office and they want nothing to do with back surgery. And I don't necessarily blame them, but I think there is a misconception in our society that all back surgery fails, and that's absolutely not the case. Back surgery appropriately done for the appropriate diagnosis by the right surgeon, the good techniques, generally speaking, will produce good outcomes. That being said, we're in an interesting time in medicine, especially this field of medicine right now. And what I mean by that is there are more advances. People want to go less invasive. Insurers are wanting to go less invasive. They're not interested in paying for $1 million multi-level fusion if the patient is going to come back complaining of pain in their back or in their legs or both. So we're looking for less invasive options. And the reason why I bring this up is these are options that I'm offering the patients. Less invasive options that often many have not heard of or are not aware of. Some of them are new, and therefore the evidence behind them are still not as robust as we would like, but some the evidence behind them are really, really strong. So that's one thing I definitely wanted to mention regarding that, because back pain is the number one cause and number one complaint of pain in the United States. It's really our bread and butter. And so I want patients to know there are multiple options. It's not just epidural steroid or surgery. There are several options out there that really need to be investigated. And again, I want to reiterate, patients shouldn't be scared of surgery if the proper, correct diagnosis has been made, the correct surgery is being recommended, and the right surgeon is going to be involved in the case. So,
and I imagine there are so many advances in surgical equipment and techniques that really have changed the way back surgeries are performed. Was that accurate?
Absolutely. In fact, it's interesting that you just said that, because I recently attended a conference with a orthopedic trained spine surgeon who trained at the Cleveland Clinic back in, I want to say, the late 70s, early 80s is when he trained. And he told us, this was just 2 weeks ago. This was 2 weeks ago in Dallas, Texas. He basically told us, in his opinion, now this is his opinion, this is not my opinion, I'm just regurgitating it. He said, in his opinion, we're in a stage comparable to where cardiothoracic surgery and interventional cardiology was back in the 80s, where interventional cardiology, because of the equipment, because of the technology, because of the techniques, we're able to treat more patients with heart attacks and save them from getting open heart surgery, and therefore we were doing less open heart surgery and more minimally invasive interventional cardiology. His argument is that we're going to tend towards that with back. We're going to be doing more minimally invasive procedures to treat patients with back pain rather than doing these big, large, multi-fusion surgeries. So I'm excited about the future. I think that's what we're seeing on the horizon.
Okay, excellent. Well, again, thank you very much, Dr. Sneddon, for being with us today.
Thank you. Thanks for having me. I appreciate it.
You're welcome. And to all of our viewers, I really, from everyone at Bingham Healthcare, I really appreciate you watching this video. And if you have any questions, please feel free to submit those in the comment section in Facebook, and we will get back to you with some answers. And again, Dr. Sneddon, Dr. Nathan Sneddon, who works at Idaho Pain Group within Bingham Healthcare. He sees patients at the Comprehensive Cares Clinic here in Idaho Falls, which is at 3302 Valencia Drive, just off of Sunnyside, right before Hit Road. And a phone number to call if you want to get more information about Dr. Sneddon or potentially schedule an appointment is 208-524-9400. Again, 208-524-9400. And again, Dr. Sneddon also sees patients in Blackfoot at 98 Poplar Street, just across the street from Bingham Memorial Hospital. And to schedule an appointment in Blackfoot, you can call 208-782-3701. Most of the time, it's good to get a referral from your primary care physician or another provider to refer into Dr. Sneddon, but in many cases, he does actually take direct appointments as well. So if you're suffering from any type of pain and would like to get some more information, please feel free to schedule an appointment with Dr. Sneddon. For additional information about him and some of the techniques that he uses, you can visit www.binghammemorial.org. Again, www.binghammemorial.org. And then under Find a Doctor, you can find Dr. Sneddon and read his bio and learn more information about him. But again, thank you very much for being with us. Again, from Bingham Healthcare, please make sure that you can try to wear your masks as much as possible in public and when you're around other people. This holiday season, try to make sure you're socially distanced and taking precautions to keep you and your loved ones safe. And then the other thing that you can be doing as well is using hand sanitizer and washing your hands as often as possible, because we care about you and we want to be able to try to promote wellness, and that's our job, is to promote wellness and health in our community. So from everyone at Bingham Healthcare, we hope that you continue to stay happy, healthy, and safe, and have a very wonderful holiday season. Thank you very much for being here.
Thank you, Michael.